Hello, my name's Simon Mitchell. I'm a diving physician and anaesthetist from Auckland in New Zealand. I'm going to be presenting on the physics and physiology of diving as it relates to assessment of fitness for recreational diver candidates. This is one of a series of lectures in the SPUMS short course on diving medicine. The target audience is primarily general practitioners who may find themselves assessing fitness for diving and recreational diver candidates. Of course, these presentations may have a wider appeal to anyone with interest in this field. So let's launch into it. Well, physics and physiology is typically the first course or first topic covered in any course on diving medicine. However, what we're going to do today is only cover those issues, but at each point we'll relate the important facts back to the issues around scuba diving fitness, or how these physical and physiological phenomena in diving relate to scuba diving fitness. Diving is a popular sport in Australia and New Zealand. It can take many forms. Typically, we see scuba divers with cylinders of air, swimming around to appreciate the wonders of the underwater environment. But of course, there are more advanced practitioners who explore shipwrecks or caves, and of course general practitioners will probably see the entire spectrum of these, but I think the vast majority of divers that are seen by doctors are going to be scuba air recreational divers. So let's just take a bit of a look at that. So typical recreational diving involves wearing a single cylinder of air as the breathing gas. That is breathed through a scuba regulator. That is what we refer to as open circuit, because you breathe in from the regulator and exhale all the gas into the water. The regulator is important. It supplies gas at the same pressure as the surrounding water, and that's an important concept that we'll come back to a few times as we work through this presentation. Of course, if it didn't do that, you wouldn't be able to breathe, you wouldn't be able to expand your lungs against the increasing pressure of the surrounding water, and we'll come to that topic too in a moment. There's what we call a submersible pressure gauge attached to the cylinder that tells the diver how much gas they've got left in their cylinder. Divers will be wearing fins. They'll typically have a wetsuit, certainly in temperate water environments. The wetsuit is made of neoprene rubber. It traps water inside the suit, which warms up and keeps the diver warm, or at least reduces the thermal loss of water, of heat into the water. And then they also wear a thing called a BCD, or buoyancy compensator device, and that's like an inflatable pair of water wings that allows the diver to put a little bit of gas into this jacket that they're wearing, which compensates for loss of buoyancy as the wetsuit gets compressed when they descend. So there's quite a lot of jargon there actually, and I've tried to summarize that in this slide. It's important that doctors are familiar with this jargon, because divers or even diving candidates will typically use these terms. Some of them I've already referred to, like a reg as a scuba regulator, a BCD as a buoyancy control device. Submersible pressure gauge is often referred to as an SPG. Underwater visibility, they'll often just say VIS. The word flippers is sometimes used for fins, very frowned upon in diving. They're fins. The tank is the gas cylinder that they wear. And then a couple of extra things. Nitrox is a term that you'll hear commonly these days, or enriched air. And basically that's a gas mix that is nitrogen, primarily nitrogen and oxygen, just like air, except that it contains more oxygen than typical air. And then there's this term technical or tech diving, and that refers to divers, the sort of more advanced exponents who are using mixed gases that contain helium for going very deep, and rebreathers for conserving those gases. We're not going to dwell on those topics today. We're going to keep it relatively simple, and the vast majority of this discussion will relate to simple scuba air diving with a single tank of air. So let's move on now and talk about the physical features and the physiological implications of the diving environment. And we're going to start with pressure. Pressure is kind of the defining change that divers are exposed to as they go diving or descend through water. And obviously, you know, it's not a difficult concept to get your head around that pressure surrounding the diver increases as depth increases. So let's have a bit of a more detailed look at that and some of the implications of it. So we'll dwell on this slide for a little while. So at the surface, as you're aware, we're surrounded by air. That air exerts a pressure. It's, you know, there are many units of pressure, of course, but we'll just, for simplicity, refer to that as 1 atmosphere of pressure. And the key thing is that for every 10 meters or 33 feet that a diver descends in salt water, the pressure increases by 1 atmosphere. So at 10 meters, there's an atmosphere of pressure at the surface of the water and another atmosphere for the water pressure for that 10 meters of descent, so 2 atmospheres. And as you can see, as you descend deeper, it just increases by an atmosphere for every 10 meters. So moving over on to the right of that, whatever gas you're breathing, and primarily we're talking about air diving here, the density of the gas increases as you descend, because, as I said before, the regulator supplies you with air at the same pressure as the water that surrounds you. The density increases as you descend. So by the time you get to about 40 meters, where that's sort of considered the limit for air diving, the pressure is 5 atmospheres and the density of the air you're breathing is 5 times what it was at the surface. And that has implications that we'll come to a little bit later. And if we look at the effect of this pressure increase on the pressure of oxygen that we're breathing, as you're probably aware, that air contains about 21% oxygen. We'll just round that to 20% for mathematical simplicity. So we're at the surface, we're breathing about 0.2 atmospheres of air, and again, that will increase every 10 meters we descend by 0.2 of an atmosphere. So by the time you're at 40 meters, where the ambient pressure or surrounding pressure is 5 atmospheres, the pressure of oxygen you're breathing will be 1 atmosphere. So like breathing 100% oxygen at surface pressure. And then the next implication, moving over to the right, is that because we're breathing dense gas at depth, when we exhale that gas into the water, as it rises to the surface as bubbles, they expand. And so, for example, a 1 litre tidal volume exhaled at, say, 10 meters, where the pressure is 2 atmospheres, by the time that reaches the surface, it's now 2 litres. If we go to the maximum depth for air diving, so 40 meters, 5 atmospheres, you exhale a litre at 40 meters, by the time it reaches the surface, it's 5 litres. And that means we're consuming our gas 5 times as fast as we would at the surface. And then the final implication of depth is that typically, not always, but typically the deeper you go, the colder it gets and the more important thermal issues become. So what we're going to do now is move on and look at some of the implications of this pressure change in a little bit more detail. So, as I've said, the pressure surrounding you as depth increases, the pressure increases as the depth increases. And that the first key implication of that is that it has effects on compressible air spaces. So anatomical air spaces like the middle ear, the sinuses, and the lungs are potentially affected. So air, or containing nitrogen and oxygen, is breathed at a higher pressure, and when we breathe gas at a higher pressure, we're going to absorb more of it. So nitrogen in particular is absorbed and accumulates in the body. And there are several implications of that, both of which we'll talk about in more detail. All of these things we'll come back and talk about in a bit more detail in a moment. But nitrogen can exert a narcotic effect at depth, and then when we ascend, the absorbed nitrogen can form bubbles and can produce decompression sickness. We'll talk about that in a separate presentation. Then, as I've shown in that last slide, as we descend and even breathing air, oxygen pressure that we're inspiring increases and oxygen can become toxic. Generally, that's not a problem until the inspired pressure is greater than about 1.3 atmospheres. And as I said before, the maximum depth for air diving, generally 40 meters, so 5 atmospheres. about 1 atmosphere of oxygen. You're breathing at that depth. So usually oxygen toxicity is not a problem in air diving, but that has fitness for diving implications that we'll come back to. And finally, as I said before, the air becomes denser, and breathing a denser gas uses the gas more quickly, and it increases the work of breathing. And we'll look at the implications of that a little bit more in a moment. Immersion itself, so moving on from pressure now, immersion itself imposes a variety of stresses. I alluded to the fact that when you're immersed in water, it's often cold, and that produces vasoconstriction, produces central fluid shifts, so a centralization of blood volume. That can cause a diuresis. It can also obviously induce hypothermia if your thermal protection is inadequate. And the loss of gravity that you experience when you're immersed in water also contributes to that central fluid shift. Again, we'll come back and talk about the implications of this in more detail in a moment. And finally, in any immersed water situation, be it a sea or the lake, whatever, you can have currents, you can have waves, you're dealing with heavy equipment, you're exercising, and all of that constitutes a challenge to functional capacity or fitness. We'll come back to that in a moment, and particularly the cardiac implications of that. So what we're going to do now is go back and look at those physical stresses that I just articulated in both that summary slide, the diagram, and that last slide we talked about, and then relate those stresses to their implications for diving fitness. So let's work our way through those things that we just listed and see how that impacts on fitness for diving. So starting with pressure, arguably the most important pressure effect on a compressible gas space is the middle ear. This is very similar to something we've all experienced, so like descent in a plane. As the pressure increases, as you descend, that pressure is transmitted onto the tympanic membrane, which of course is pain sensitive. That will cause discomfort, and that's what people obviously complain about as they descend in planes. It's also important to understand that that increasing pressure is transmitted evenly throughout the body, so even the soft tissues that line the inner ear will become pressurized and try and compress into that airspace. And in order to prevent damage from this, you have to compensate it by forcing the compressed gas that you're breathing up through the eustachian tube so that it prevents the eustachian tube bowing inwards and prevents that soft tissue lining the middle ear from essentially bleeding or being traumatized inwards. And if you don't do that early in the descent, one of the problems can be that the soft tissues lining the eustachian tube are also compressed by this general transmission of pressure through the body, and the eustachian tube can become occluded. So one of the key things that diving instructors teach divers is to equalize pressure in their middle ears early and often during the descent. If you fail to do all of those things, or do that, then that can result in tympanic membrane rupture, a middle ear effusion, or bleeding into the middle ear. And we refer to that under the general terms middle ear barotrauma. And I'd say it's common knowledge that it would be the most common diving injury that we see out there in recreational diving world. What about other gas spaces? Well, there are sinuses, as you know. Interestingly, the sinuses are usually not a problem because unlike the middle ear, where the eustachian tube is a bit floppy and needs to be actively opened by most people, the sinuses communicate with the nasopharynx via quite wide ostia, or little passages through the bone. And so they usually self-compensate. They usually look after themselves from the compressed gas that you're breathing. It just gets its way up into the sinuses and compensates for pressure in them. However, if those ostia are blocked by anything, if you've got a cold or there's a polyp or something like that, then you can get sinus barotrauma. The lungs are interesting, and we'll talk quite a bit more about this later, but the lungs aren't actually compressed during a descent because, as I said before, the scuba regulator supplies you with gas at the surrounding pressure, and so that allows you to expand your lungs normally with denser gas to compensate for the extra pressure that surrounds you. So the lungs generally aren't aren't compressed. However, in a compressed gas dive. However, ascent is a different story, and we'll talk a bit more about that in the next presentation that I'm going to do, because there can be pulmonary barotrauma during ascent. We'll come back to that. And finally, the mask itself, which contains air, is a compressible gas space, and during descent, as the pressure increases, divers have to exhale into the mask in order to compensate the increased surrounding water pressure. And failure to do so may cause so-called mask squeeze, and that's what you see in that photograph there, where you can actually get a periorbital hematoma or subconjunctival hematomas because those tissues are trying to bulge into the mask and take up space in that negative pressure area inside the mask. So you need to compensate pressure in the mask. So with those pressure effects on compressible gas spaces in mind, what are the fitness implications? Well, the most obvious one is that in order to be a diver, divers have to be able to insufflate the middle air via the eustachian tube. It's kind of a non-negotiable thing. That has to happen. Obviously, a red flag is difficulty equalizing pressure during descent in planes. If someone tells you that, it could signal problems. Doctors doing diving medicals have to assess this typically by directly visualizing the tympanic membrane while the diver performs a Valsalva maneuver, so that you can see the tympanic membrane move in response to that Valsalva maneuver. If the diver is truly unable, which is rare, then they're likely unfit for diving. However, it's worth bearing in mind that marginal candidates can be taught to do the technique perhaps better than they've been able to in the past, and diving instructors are good at this. However, I think it's important, if a candidate does have what you might call sticky ears, that the diving instructor is informed of this so that they can concentrate on teaching that technique and performing cautious descents during the course. Sinuses must compensate during descent, and as I said before, that usually happens automatically, but if there's a history of difficulty with that in planes, it might signal problems or potential problems in diving. It's not possible to formally assess that, unfortunately, in a medical environment. However, if there is such a history, then again, communication with a diving instructor who's going to be teaching the diver is probably important, just to warn them that that might be an issue and to be cautious during descents. So the next physical stressor is the effect we mentioned on inspired gas pressures. So remember I said that as we descend, the regulator is supplying us with gas at the surrounding pressure. So the PO2 in the inspired gas, the pressure of oxygen, increases linearly with the increasing depth, as we saw in that diagram previously. And not only that, some divers, I mentioned this before, use these nitrox mixers, meaning they've actually got a higher inspired fraction of oxygen and therefore higher inspired PO2s at even shallower depths than you would get with air. Why do divers do that? The advantage is a reduction of the inspired nitrogen and nitrogen absorption, so arguably less narcosis and longer durations before nitrogen absorption becomes an issue for decompression. We'll talk a little bit about that later as well. But look, the key thing about the fact that oxygen is increasing as we descend is that hyperoxia is epileptogenic. And although the pressures of oxygen we develop in air diving to the maximum air depth of 40 meters are typically benign and safe, oxygen toxicity can produce a grand mal seizure with little or no warning if those pressures are exceeded. So I think I mentioned 1.3 atmospheres of oxygen. Air divers would rarely encounter that unless they go unwisely deep, but certainly some of the divers using nitrox or the more advanced technical methods can sometimes encounter those kind of pressures. We'll come back to the implications for fitness in a moment. It's probably worth pointing out that divers do follow guidelines for safe oxygen exposures, and mostly this keeps them out of trouble. However, there are fitness implications that we'll come to in a moment. So, what are those? Well, it's important to understand that divers are exposed to epileptogenic stimuli that are not normally encountered by non-divers. And primarily high PO2, as I just mentioned, is the thing we're concerned about. But there are one or two other factors which we'll talk about a little bit later. So that forms part of the reason why epileptics are considered unsuitable for diving, even if they're stable on medications. And the point about that is that although someone may say, well, look, I'm stable on my medications, I haven't had a seizure for years, the problem is they haven't been exposed to these epileptogenic stimuli in diving, which could quite markedly change their risk. So we generally say no to epileptics. However, there is advocacy for, somewhat controversial advocacy, for epileptics who have been seizure-free off medications for at least 5 years to be considered with an informed risk acceptance paradigm applied. I will say that is controversial. And my advice would be that if someone is approaching you with that kind of history, it's probably best if they talk to a diving physician. And it's also worth pointing out that we don't count childhood febrile convulsions with no subsequent problems as implying any kind of increased risk with hyperoxia. So we can exclude them and not worry about childhood febrile convulsions. It's also worth exhibiting some caution for exactly the same reasons following severe head injuries. So divers who've had severe concussions, especially where unconsciousness was involved, we know that they are at risk of developing epilepsy as a result of those head injuries. So very careful consideration needs to be given to them if they want to dive. And then finally, although this is relatively rare, an elevated inspired oxygen is considered a risk for developing pneumonitis in patients who've previously been exposed to bleomycin, a chemotherapeutic agent mainly used for treating germ cell tumours like testicular cancer. And if someone has a prior history of bleomycin exposure and they want to dive, I would consider referring them to a diving physician for an assessment. So the next physical stressor is the inspired gas density and the effect that that has on worker breathing. So I think you all know that carbon dioxide is eliminated by breathing, and we adjust ventilation to remove more CO2 or less CO2 based on input from our central and peripheral chemoreceptors. If CO2 starts to increase, then we breathe more. If CO2 decreases, we may breathe less. That's all happening automatically in all of us all the time. We don't think about it. And it's an important homeostatic mechanism that keeps the carbon dioxide where the body wants it. One of the fascinating things about increased work of breathing, especially when you combine it with exercise, is that the sensitivity of that mechanism gets reduced. In other words, you become less responsive to high carbon dioxide levels if you combine an increase in work of breathing, which gas density increase will do, with exercise. So we see this in diving. We're breathing dense gas, high work of breathing, and we're exercising. So the point is that an exercising diver underwater may retain carbon dioxide. In other words, their CO2 levels build up. And that of itself can produce unpleasant symptoms such as shortness of breath, headache, shortness of breath, and a sense of anxiety. But even more importantly, a high CO2 causes cerebral vasodilation and increases the exposure of the brain to oxygen. So if you combine high CO2 with high PO2, then that epileptogenic stimulus that's provided by high PO2 is even worse because the brain is exposed to a higher dose of oxygen. So let's look at the fitness implications of that. And they're relatively limited for scuba air diving, but CO2 retention can, as I've just implied, can actually enhance the epileptogenic effect of elevated inspired PO2. And that forms another strong argument for against diving by epileptics, by people suffering epilepsy. Okay, so we've considered the implications of pressure and all the changes that that brings. Now what we're going to do is talk about the implications of immersion, so the physiological changes and how those relate to fitness. So, immersion has fascinating effects on cardiac physiology, and actually a lot of this stuff does get taught at medical school, so many of you will be familiar with this. But again, I'd like to go to a diagram to try and summarize some of the important ones. Look, this is a relatively straightforward diagram of the circulatory system with the systemic circulation labeled tissues there and the pulmonary circulation labeled lungs. You can see I've kind of created a single alveolus model of the lung in the lung section, and then of course you have the heart in the middle of it all, and it requires no further explanation for an audience of this nature. So what happens when we immerse ourselves? Well, especially if the water's cold, we see a peripheral vasoconstriction. And that, as far as the heart is concerned, it increases the afterload, peripheral vascular resistance, and that will produce a degree of hypertension. Virtually everyone's blood pressure will increase when they are immersed. The next thing that happens is, because of that peripheral vasoconstriction and because of the loss of gravity and venous pooling in the distal veins, we see increased venous return, so an increase in preload. And it's worth just pointing out that that's quite a significant burden on the heart that occurs simultaneously, an increase in afterload and an increase in preload. So the heart is having to cope with more blood arriving and more resistance to pumping it forward. So a significant cardiac stressor. And then other things we see in relation to the pulmonary circulation are an increase in pulmonary capillary pressure and an increase in pulmonary venous pressure. And those are logical things if you think about it. If you've got an increase in blood returning to the left heart and more resistance to the left heart pumping it forward, the pressures in the pulmonary circulation are likely to increase. And those changes are even more likely to occur if the heart is impaired in any way by disease or by drugs. And we'll talk a little bit about the implications of that a little bit later. And all of those things are exaggerated if you're exercising at the time, or if the diver is over, or the person immersed is overhydrated. So I hope what I've created with that diagram is a sense that immersion itself creates quite significant changes in cardiovascular physiology and a significant burden on the heart. Okay, so this slide just summarizes some of those things I've been talking about. So these changes in cardiac physiology: increased preload, increased afterload, hypertension, almost inevitable when you get in the water, an increase in pulmonary artery pressure, and an increase in myocardial work. And of course, that will be exacerbated by exercise. Now, there are a number of consequences of these things, and one of them is that the centralization of blood volume, stretching of the atria, secretion of atrial natriuretic peptides. What you'll see there is a diuresis. So what often referred to as immersion diuresis, and the reason why people feel the need to pee when they spend time in the water. And that can lead to dehydration. Of course, all of that stuff that I mentioned on that last slide adds up to myocardial strain and potential ischemia if there's any compromise of myocardial perfusion. That, of course, could produce arrhythmias and a myocardial infarction. And it's worth pointing out that there are very solid data in the literature that suggests that about 25 to 30% of diving fatalities have a myocardial event as a trigger. So this is not a trivial issue. It's a big issue, and it plays into the cause of many diving fatalities. The third thing that is a consequence, as you saw in that previous diagram, there's changes in pulmonary pressures, the increase in pulmonary artery pressure, the increase in pulmonary venous pressure, that can produce this phenomenon called immersion pulmonary edema. And I think that will be dealt with in more detail in a further lecture, but at least that provides some of the background as to why pulmonary edema might occur. So what are the fitness implications of these physiological challenges that we see with immersion? Well, obviously, cardiac fitness is an important element of fitness to dive. And there are some obvious things that you would exclude if you're bearing that in mind. So anyone with symptomatic heart disease, moderate to severe valvular disease, cardiomyopathies, they are fairly obvious contraindications to diving. Now, it's worth pointing out though that some of these things can be treated, and if they are detected and treated, and the diver or the candidate can subsequently demonstrate good functional capacity with no ischemic change, then people can go on and dive, but they need to be treated and demonstrate that they have been successfully treated. Poorly controlled hypertension is a relative contraindication to diving, and notionally we define that as systolics more than 140, diastolics greater than 90. Treating someone like that is good for them whether they're a diver or not, and we would generally advise that blood pressure should be well controlled before divers dive, because they will experience higher blood pressures in the water. We'll talk a little bit about treating hypertension in divers briefly in a moment. Any history of poor functional capacity of potential cardiac origin does need further investigation. There may be important cardiac causes for this. I guess one of the questions that arises from that comment is, well, what constitutes adequate functional capacity or poor functional capacity? That's controversial, actually. But there is a consensus that divers, for recreational diving, the typical scuba air diving, they should be able to produce a steady 5 to 6 MET output, which sort of corresponds with finning in the water at about half a knot. That would be a bar that we would kind of want them to get over in order to be successful or safe divers. I'd like to reflect actually right now at a practical level what triggers cardiac investigation in most of these diving candidates, and that it kind of involves explaining to you how a diver might filter their way to you as a general practitioner. You may not be aware that the way that divers are screened for diving fitness these days mostly involves a screening questionnaire, and if they are kind of all no to everything on the screening questionnaire, then they actually just progress to their diving course without a diving medical. However, if there are any positive responses on the screening questionnaire, that's when you would get to see them. And this is what the screening questionnaire that's in common use around the world looks like. Now, I'm not going to get into this in any detail, but you can see there are 10 questions, and if it's no to everything, then they will go straight onto their diving course with no need for a diving medical. However, if we look at the questions that might pick up a cardiac problem, you can see there are 3. So I've had problems with my lungs, breathing, heart, blood, or have been diagnosed with COVID-19. So there's heart is in there. And then I'm over 45 years of age. And if you tick yes to that, then you have to go to box B. The first one, you have to go to box A, and I'll show you those in a moment. And then at the bottom, I'm taking prescription medications with the exception of birth control or malarial drugs. So any prescription medications other than those drugs, then they have to come and see a doctor. So I'm over 45 years of age, go to box B, and box B says, if you say no to all of these, you don't need a medical. Just being over 45 doesn't necessarily mean you do, but if you're over 45 and yes to any of these, so smoking, high cholesterol, high blood pressure, or a family history of significant heart disease, then you'll need to be seen by a GP or a diving doctor for a diving medical. And this is how most of them will come to you. With this kind of history. I'm over 45 and I smoke, or I'm over 45 and I'm treated for high blood pressure. And then box A was, I've had problems with my heart, lungs, breathing, etc. And there's a variety of questions there that would trigger them to come and see you. I would say that the 45 years old and a positive answer to one of those questions in box B is how many of these cardiac issues will end up with you. And so the system will direct them to you, and then you're faced with, well, what do I do? And This is a very good, relatively contemporary paper that was put together by a committee of experts in SPUMS, and it provides some guidelines as to what to do in that situation. And again, we won't work through this in detail, but in that paper you will find this flowchart. And essentially, let's just say it's a 45-year-old who smokes. So they don't have symptomatic heart problems. You do a 12-lead ECG, it's normal. You apply one of the sort of cardiovascular risk assessment tools, and if their 10-year risk is less than 10%, then they can just progress. If it's more than 10%, then they progress into an investigation regimen. And most people would consider a coronary calcium score as a good starting point. And if it's less than 100, then they can usually progress to diving. If it's more, then we would usually refer them to a cardiologist. And look, this is all sensible stuff for cardiac risk management in anyone, actually, but particularly in divers. So we won't dwell on this any further, but it's just to give you a sense that there are guidelines there to help you with these kind of assessments when these sorts of candidates turn up. Continuing on with these fitness implications, remember I pointed out that you see an afterload increase and this diuretic effect of immersion. Then one of the things that we do point out is that beta blockers and diuretics are not ideal first-line agents for treating hypertension in divers. So beta blockers can impair the cardiac response to those physical stresses of immersion. And may actually be a precipitant, although we're not sure, the data are soft, but they may be a risk factor for immersion pulmonary edema. And you can imagine why, like simultaneous increase in preload, simultaneous and afterload, and you're on a beta blocker that prevents your heart adjusting to those changes. It's not that surprising that that could exaggerate those changes in pulmonary vascular pressures that might predispose you to pulmonary edema. And diuretics, of course, could exaggerate dehydration, the immersion diuresis thing. So we don't want hemoconcentration in diving. It's a potential risk factor for decompression sickness. So beta blockers, diuretics, probably not best choice. Calcium channel blockers, ACE inhibitors, angiotensin receptor antagonists, they are considered better choices in divers. So that's a bit of a walk through the physical and physiological changes we see in diving and some of the fitness implications. I just want to spend a couple of minutes at the end of this presentation giving you what we've referred to as a functional analysis of diving. Now, this isn't specific to the physics and physiological challenges of diving, although it helps put diving into context. If you're not a diver yourself, then understanding what the physical requirements, the cognitive requirements of diving are, it's difficult. So this is an attempt to construct a functional suite of characteristics that a candidate should have in order to be a successful, safe and independent diver. So it's not to be confused with a list of tests that you have to pass. And some of the elements of this functional analysis can't be evaluated in an office-based consultation. And I've kind of explained what the point of it is. So just to work through a few slides, a prospective diver should be capable of the following things. They need to be able to acquire and apply a relevant diving theory knowledge base. So gas laws, for example, simple things like Boyle's law, pressure is inversely proportional to volume. That is one of the things that makes it challenging for very young children to become safe, independent divers, or someone with an intellectual disability. Working as a team and adhering to pre-agreed systems and a dive plan. So most adults are capable of that, but it does flag the possibility that someone with a behavioural disturbance might not be a suitable candidate for diving. Tolerating the psychological stress of total submergence in water, that sounds obvious, but you might be surprised at the number of people that come to you and say, I want to go diving because I've got this morbid fear of being out of my depth in water. And that's something that needs to be considered, and if the diver does, or the candidate progresses, may be flagged to a diving instructor. So lifting and carrying individual items of diving equipment on land, to be an independent diver, you need to be able to do that. And just for reference, a fully assembled scuba set weighs about 23, 24 kilograms. So it's not inconsequential. And so diving is going to involve someone in being able to manipulate weights and walking with weights of that magnitude. This kind of reflects that. So standing from sitting and walking 30 meters without fins, like walking across a beach to get into the water, that would be another functional requirement of diving. And similarly, ascending out of the water on a vertical ladder wearing standard scuba equipment to get out of the water onto a boat, for example. Now, of course, there are ways of, finessing these things if people don't have these capabilities, like, for example, passing equipment up and someone else hauls it out of the water, or someone takes equipment into the water for someone and you put it on in the water. But if you want to be an independent diver, then these are the characteristics that you need. Insufflating the middle ears via the eustachian tubes, we've talked about that. Swimming underwater at half a knot for 30 minutes in standard scuba equipment, a continuous output of 5 to 6 meters, we've talked about that. Ideally, someone should be able to elevate their functional output, their exercise output, to about 10 to 12 METs for a short period of time. Not everybody can do that, but the idea there is that you could swim your way out of a current, for example. Finally, last slide, maintaining a protected airway with a scuba mouthpiece in place when you're totally submerged. And it will go, although again kind of obvious, that would disbar anyone who, for example, has got a facial nerve palsy, can't seal their lips around a regulator, has a tracheostomy. Believe it or not, I have seen someone with a tracheostomy wanted to go diving. Not a possibility because of this. And then vision, so seeing near and far objects to allow you to read gauges like your SPG, or recognize distant entry and exit points, before and after a dive. So corrected visual acuity of about 612. Look, blind people have dived, but again, they're not independent divers. So this functional analysis is designed to reflect the characteristics that you need to be an independent diver. So look, I'd just like to say thanks for watching this video. I hope that it has given you some sense of the physical and physiological changes that we see, some of the diving fitness implications, a few references that will help you, particularly with the cardiac evaluation of patients. And just bear in mind that we're very lucky in Australia and New Zealand. We have a very good network of diving physicians. Every state capital in Australia has a large hyperbaric medicine unit in a public hospital. The diving physicians there are usually happy to be contacted if there are any tricky things, and there are diving physicians to refer to. But the whole idea of these videos is to improve the penetration of diving knowledge into our GP community, because you really are the front line. You're the people that are seeing these divers most commonly when they present for diving medicals. So we're very keen that you feel comfortable doing those kind of things, those kind of medicals. Thank you very much.